So there's a bunch of cardiac drugs out there. Gonna break it down a little bit. This week we're just gonna cover hypertension. Otherwise we'd have hours upon hours of studying. And there are classes out there that deal just with cardiac drugs. You can actually take a certification on cardiac medication. So we're not going to go in super detail about them, but we'll break it down over the next week. Probably is when we'll finish it. Maybe next week or 2 more weeks. At any rate, I really think it's important that we cover not only the drugs, but we understand how it works in the body. That way, just like with anything else, if something goes wrong, we know what's happening that causes that. So today we'll cover hypertension, and we'll talk about common hypertensive medications, first line treatment and whatnot. I did forget one medication classification, which I'll go over, and I'll cover that more in detail next week. But at any rate, I hope everyone's week was good. Mine was really good. I had a birthday. I'm 1 year older. I won't tell you how old I am. I'll just let you guys guess. But that was on Thursday. And the exciting thing that happened today, well, a couple exciting things. My brother got a car, which is nice because now he doesn't have to borrow mine. But I bought a sound system for my car for my birthday, and I had it installed today, so now you can hear me coming down the street. My neighbors are going to love me, and I am awaiting my letter from the Homeowners Association, the HOA, about my loud car. But that's okay, because they won't have to deal with me if I move. Not that I'm going to move anytime soon. Oh, and the other exciting thing is it got cooler here in Texas, so now I can enjoy the weather outside without boiling and sweating in the morning. It was really, really nice. I was able to sit out there, and there weren't any bugs bothering me. It was really nice. And this was the weather I've been waiting for a long time. Anyway, let's start with some shout outs. I want to thank again 4K DRXFT. They followed me last week, and you guys can follow me too. Use them as an example. I want to build this following so that we can talk more one-on-one. You guys get involved in the chat, ask questions. I don't care if you're in nursing or not, or healthcare. Maybe you're thinking about it. Maybe it's something you've wanted to do and you just want to learn more. Type a question in the chat. Let's talk about it. I know that there's some of you that repeat, come back every week. So just hit follow. Doesn't cost you anything. But it helps support Twitchy Nurse. I can open up new ways to view things. So just follow me. You can also follow on Instagram. You can follow on Facebook. I have TikTok, but I haven't really updated that in a while. I need to, but I just haven't. But I'm going to be doing more with my Instagram to ask questions, to be more interactive with you guys. So please follow, like, subscribe, all of that, and we'll get going. For Instagram, like I said, I was doing more with it. I'm asking questions. I want to test your guys' knowledge. I want to challenge you guys. And I'm very thankful for those who participated in the poll to figure out what we were going to study this week. A couple people I'll shout out because I like to shout out to you guys. And thank you guys for participating. So let's see. Rachel Dangatang, Sheree RN, and Will Leo G. Thank you guys very much for participating in that poll and answering the question and choosing what we were going to study today. And on that note, let's get started. So, we're going to cover cardiac medication, but we're going to break it down because there's so many cardiac medications out there. And eventually I want to get to vasopressors, like drips that you run in the ICU and in the ER. I also want to cover some medications such as statins for high cholesterol, antiarrhythmic drugs, and then also drugs that go along with the circulatory system such as blood thinners and whatnot. At any rate, we're going to start with hypertension because that'll kind of set a base for everything else that we're going to talk about in coming weeks with the other medications. So we're going to talk about beta blockers, calcium channel blockers, angiotensin converting enzyme or ACE inhibitors, and diuretics. And one medication classification I missed is ARBs, or angiotensin receptor blockers. So I'll talk more about those next week, but if you understand these, that'll be really easy to cover. By the time I got this study session stuff set up, it was almost time to start. I was very late in doing these. At any rate, so we'll cover these and it'll be fun. So let's start with hypertension. What is hypertension? What causes it? It's also known as high blood pressure, but there's certain things in the body that happens. With age, our blood vessels tend to get crunchy, if you think about it that way. They stiffen up a little bit, they become less elastic. We have atherosclerosis. I have trouble pronouncing some of these medical words, so you'll have to just kind of bear with me. But anyway, that's a plaque buildup that can occur in the blood vessels, which will cause hypertension. I have a picture that kind of goes over that. Certain diseases will cause hypertension. Kidney disease, if our kidneys are damaged, our kidneys have a lot to do with blood pressure management, with getting rid of fluid, holding on to fluid and whatnot. So kidney disease, renal failure, that all can affect and cause hypertension. Some medications and street drugs can cause hypertension, smoking, thyroid problems. So a lot of this can be caused by other things that would be more secondary hypertension, but most hypertension is caused by those blood vessels, buildup of plaque, and the stiffening. So if you see here, in a normal blood pressure, I like to think babies have this arterial wall, nice and clean, nice and open. You can see the blood just flows nicely in. The lumen of the artery is nice and open, so that blood can just easily flow. But as we have some buildup, either thickening of the vessel wall or we have some plaque buildup, what we do is we cause the lumen to get smaller and smaller. And if you think about the arteries like a hose, when you make the opening of the hose smaller and smaller, either with your thumb or with a nozzle, and we restrict and we make that lumen small, it's going to shoot out. There's a lot of back pressure that's going on, and it just shoots out really strongly because it's very high pressure system at the moment. So when we decrease that lumen side, that blood is still being pumped because it's got to get to where it's going. It's still being pumped, and it's causing it to be pumped at a higher pressure, that little tiny lumen. This can also cause your heart to work more, because now instead of the heart pushing against these nice open vessels, they're having to push all this blood through this tiny little opening. So hypertension can cause cardiac issues if not treated, can cause damage to organs, it can cause a lot of different things. Because if you think about it, if you're pumping blood and you're pumping it through a tiny lumen, so you're basically pressure washing blood to these organs because the lumen's so tiny, you could cause damage. It's that high pressure blood being pushed against those organs. So Hypertension. You gotta control it. So here's some categories that you don't need to memorize. Well, you do need to memorize, actually. Once you start working with them more, it's easier to remember. But you want to know what's elevated. You want to know what's considered clinical high blood pressure, and then also hypertensive crisis, because not only will you be tested on it, and you'll have to interpret vital signs on tests, but if you have a patient and they come in with symptoms, or they just measure their blood pressure and they say that's high, you know the ranges for it. So normal, we like the systolic to be less than 120. We like the diastolic to be less than 80. 120 to 129 is elevated. And this is newer guidelines from the American Heart Association. I'll tell you right now, I probably live in an elevated blood pressure. I think back when I started nursing school, 120 over 80 was normal. And if you were 120 to 130, you were still doing pretty good. I think mine is normally 124 over 78, 79. There's one time I was working night shift at this time, and I was in the Army, and I actually had like a 150 over 89 or something, and everyone was freaking out, and I said, well, I just worked night shift. I just got off of my shift. I'm tired. It was a stressful shift. I promise you I'm not hypertensive. But, I mean, maybe in that moment I was, but I don't have hypertension. And sure enough, I'm normal. I have a normal blood pressure. If your body's under a lot of stress, I know when I had an allergic reaction, I was super high. It was like 182 or 200. No, it was 120 over like 109. No, I'm sorry, 200 over 109, not 120. It was up there, and I turned to the nurse at that point. I said, can we retake my blood pressure? That's really high. But anyway, so in order to understand how all this works, we need to go over anatomy and physiology. So this is going to be on a micro level. We know the structures of the heart. We know the structures of the blood vessels. Very basic, you know, the different layers of the wall. What I'm talking about is receptors. So we're going to go deep dive and get microscopic level of anatomy. So we have a couple of receptors. We got alpha receptors, and there's alpha 1 and alpha 2. So alpha 1 affects the smooth muscles of the vessels. That's the muscle that's on the artery wall, and it affects those muscles. When it's activated, it tends to constrict them. Then we've got alpha 2, and those are located in the brain and the periphery, and that deals with the sympathetic pathway. So alpha 2 modulates sympathetic outflow, so it causes that sympathetic pathway to be activated. And if you remember, I have to always remember this, sympathetic is when we're in our fight or flight mode. So that's what's going to cause our body to react to be able to either fight or just run away. Okay. Then we've got our beta receptors, and this also has a beta 1 and beta 2. So beta 1 is located in the heart, and this beta 1, when those get activated, it'll increase our heart rate, it'll increase how strong the heart pumps or contractility. And then beta 2 are located in the bronchioles in the lung, and also in our skeletal muscle, the arteries in our skeletal muscles. But this is important because some medications will affect one type of receptor or one type of catecholamine receptors, and the other will affect other one, or medications can affect one or the other, is basically what I'm saying. And then you've got medications that are non-selective, or they can go to any one of those. So it's important to know where your receptors are so that you're able to tell which medication is affecting which one. So here's a good little chart. Don't worry about this on the bottom. When we start talking about vasopressors, this is going to make more sense. But we release norepinephrine and epinephrine when we get into our sympathetic pathway. And our receptors have more affinity to some versus others. So alpha-1, here you can see this is the receptors that will cause vasoconstriction. It will increase the resistance or blood flow, increases the blood pressure, causes our eyes to dilate, and it tightens up our sphincters, right? Because we don't want to be peeing ourselves when we run, right? We inhibit norepi, we inhibit insulin, we want to be able to have glucose circulating around. So then beta, we increase our heart rate, we're going to be using fat stores, we are going to increase our heart contractility, we're going to increase our renin so that we are ready to go. We're going to then beta 2, we're going to activate, which causes our blood vessels to dilate, so we get blood pumping everywhere. We have some bronchodilation so that we're able to get air into our lungs. We're going to get some glycogen from our muscles and liver. And then this doesn't really matter for when you're running, but it also affects your uterine smooth muscle. Okay. So now that we've gone over where and what alpha receptors do, let's talk about alpha blockers. And these aren't as common. I don't see them a lot, but it's important to talk about because you can still see them. So these are going to have the last, all these drugs have different names, and when you're in a certain classification, there's similarities between all of them. So for alpha blockers, the last syllable is osin. So if you see a medication and you see osin at the end, it's a pretty good chance that it's an alpha blocker. So some of those common medications, tamsulosin and prazosin. So the T1 is Flomax. I can pronounce that a lot better. And that's when you have BPH. You can give this medication. It relaxes the smooth muscles around the prostate and the skeletal muscles so that men can pee easier. And prazosin is mini press. And this is a drug that I will give my patients for blood pressure, but not as frequently as other medications. A lot of alpha receptors are located in the prostate and the muscles surrounding the ureter. So what this does is it fills in all those receptors so that the catecholamines can't get into those receptors. So it blocks catecholamines from getting into those receptor sites. And as a result, it causes the blood vessels to dilate and lowers your blood pressure that way, or relax. It causes those muscles to relax so men can pee with Flomax. Like I said, it's not used as much for hypertension. You'll see it more often when you see like BPH, benign prostate hypertrophy. Okay, talked about that. So a couple of jokes to help you remember. Does the beta blockers make you more alpha? Okay, I thought I had one more. I guess not. Anyway, okay, beta blockers. So this is a lot of people you'll notice will take this, and this is across medicine. And beta blockers have the last syllable as lol. Sometimes you have OLOL. Sometimes you just have LOL. At any rate, beta blockers, just like your alpha blockers, will fill in those receptor sites to cause catecholamines to not stick in there. So there are two types. There's cardioselective and non-cardioselective. And it's important to know this because if you have a medication that will block both, like propranolol, cardioselective and non-cardioselective areas that the beta blockers are at, so you know beta 1 is in the heart, beta 2 is in the lungs, then it's going to cause either constriction or dilatation in those different areas. So it's important to know if your beta blocker is cardioselective or not. So here's some: metoprolol, atenolol, and propranolol. And remember, propranolol is non-cardioselective. So they fill in those receptor sites, and I have a picture here, and it causes the epinephrine, the norepinephrine, those catecholamines, they can't get into those receptor sites. So since those catecholamines can't get into the receptor sites, it can't constrict those blood vessels. So our blood vessels relax. This will also lower our heart rate if we've got beta 1, cardioselective, relaxes muscles around the blood vessels. And then here's to help you remember, so beta blockers know that laughter is the best medicine, right? So LOL, they have the last few letters of LOL. And then here's a picture. You can see the receptor sites. The beta blockers fill those receptor sites and on the tissue or the cardiac tissue, and it causes the epinephrine and norepinephrine to not be able to get into those sites because those seats are already taken. It's kind of like musical chairs, if you've ever played that. Those beta blockers get into those chairs first, so very few of the catecholamines can get in there. All right, labetalol. This is a combination drug, so it has alpha and beta blockers. It's a very effective medication. It acts very quickly. A lot of times I've given this in the ICU. I've also given it in the PACU, and sometimes I've called it Trandate. It can be named Trandate, and I always get funny looks with that because I think that's an older name for it. At any rate, labetalol, that is a combination alpha and beta blocker. Let's see if I can fix it. Okay. All right. So things to remember at that: you got alpha, you got beta. Which one are you going to pick? Well, labetalol takes both. And then here, the panda. Labetalol is the panda of drugs. You got the black bear and the white bear. They're chilling together. They come together and make labetalol. All right, there's something you need to know about beta blockers. It can affect your normal physiological responses. So, because a patient is on a beta blocker, if they become hypoglycemic, if their blood sugar drops, they don't always have the increased heart rate to compensate like someone who is not on a beta blocker. So you may have a patient coming in with altered mental status, and you notice they're on a beta blocker. Might be a good idea to take a blood sugar. They might be hypoglycemic. These patients, sometimes that hunger drive is not there either. So they become hypoglycemic, but they never get hungry to get their blood sugar back up. So it's really important that you notice if your patient is on a beta blocker that they will not have an increased heart rate in some of the compensation mechanisms. Another one is hypovolemia. You have a patient on a beta blocker and they're bleeding out or they're dehydrated, they may not have tachycardia. They may have a heart rate in the 60s, 70s. And so it's really important that you make sure you know your patient's medication. And that's another thing. If you take medication or you have family members that take medication, make sure that they have a medication list on their person. You can put it in your cell phone. I know I use cell phones a lot in my ICU. There's a feature, at least on the iPhone, I know on the Android they have it too, where you don't have to log into the phone, but you can get emergency contact information. And in that emergency contact information, you can put certain illnesses or diseases you have, and also medication you take. I've seen people write it on a piece of paper and put it in their wallet. Almost everybody keeps their wallet on them or their purse on them, and it goes into the hospital with you. So if you're unable to answer any questions, if you have an altered mental status or you're completely unconscious, we're able to look through things and we're able to see that medication list. So it's really important that you have a medication list on your person, or tell your family members to carry it. So here's a way you can remember beta 1 and beta 2. So beta 1 blockers affect the heart. If you do a heart shape, 1B fits in the top. And then beta 2 blockers affect the lungs. So if you do 2 Bs that look like a butterfly, you got the lungs. All right, calcium channels. So on all of our muscles, we have calcium channels, and when nerves are excited, it releases calcium into the cells, which can cause muscle contraction. And I won't get totally in depth into the physiology of this, but just know that when your cells have calcium going into it through the calcium channels, then your muscles can contract. So when you have a blood vessel and the calcium is going into the smooth muscle of the blood vessel, what happens is that blood vessel muscle contracts, causes that lumen to get really small. So then we got calcium channel blockers. And if you guessed that these medications block the entrance of calcium into the calcium channel, you would be correct. So these medications, there's 2 kinds. One, and I'm going to butcher it. I don't really normally use this word, but it's important because there's 2 types of channel blockers, and depending on how the medication generic name ends is how you know what it's affecting. So diphenhydropyridine, notice that these end in an INE. So if we get here, INE. So these medications are amlodipine, nicardipine, nimodipine. These affect the blood vessels. They don't really have a lot of effect on the heart. They have a lot of effect on your blood vessels. So amlodipine and nicardipine. Amlodipine I give a lot in a pill form. Nicardipine, if I have a patient that I need to really strictly control their blood pressure, maybe they're in a hypertensive crisis from the ER, or we just had brain surgery and we need to keep their blood pressure below a certain number, we can actually do this in a drip format in the ICU. So we got nicardipine, and then nimodipine, nimodipine. I gave that a lot when I worked in a neuro unit, and that helps prevent vasospasms. So vasospasms is the narrowing of the blood vessels in the head, the arteries mainly. So nimodipine, these patients would get that to prevent the vasospasms in the brain. So these all act on the vascular smooth muscle. And remember, if it has INE, it's affecting the blood vessels. So if you look here, you got a muscle cell. The medication blocks calcium from going in there, and that causes the blood vessels to relax. We got vasodilatation, decreased blood pressure. Now the second type of calcium channel blocker is non-diphenhydropyridine. Pyridine. These are antiarrhythmics, and if the channel blockers have no INE, that's when you know that it is not acting on the blood vessels, but it's acting on the heart. Okay, so no INE means that it is actually an antiarrhythmic, or it's working on the heart more than it's working on the blood vessels. It's a very weak response in the blood vessels. So what are these? So verapamil, diltiazem, these are antiarrhythmics. They can help the heart pump a little bit better. Like I said, it acts on the heart. Okay, so here is what I was saying. So here, the dihydropyridines have more effect on the blood vessels, the vascular, and less effect on the heart. And then here, the non-ones have less effect on the blood vessels and more effect on heart function. So, two types of calcium channel blockers. Remember, INE and no INE. We'll talk more about antiarrhythmics next week. Okay, now we get into the angiotensin-renin system. So, this is where I told you about the kidney disease. Kidneys really play a big factor on hypertension, and sometimes when the kidneys feel like they're not getting enough blood flow, they'll cause your blood pressure to go up, which then causes damage to your kidneys, which causes just a never-ending cycle, right? All right, so in a normal functioning body, renin is secreted by the kidneys. We got angiotensinogen and angiotensin floating all over our body at any time. So then angiotensin converting enzyme, which is also known as ACE, that enzyme lives inside the vessel walls, so the walls of all the blood vessels. So when a low blood pressure occurs, it sends a message to the kidneys that I'm not getting enough blood flow, so I'm going to release renin. That comes over, it causes angiotensinogen from the liver to convert to angiotensin 1. Then ACE, angiotensin converting enzyme, causes angiotensin 1 to convert to angiotensin 2. Why our body is so complicated like this, I'm not sure. It's something I'd have to ask God, if you believe in God. But yeah, that's one question that is on my list to ask him, why this system is in existence, why we couldn't just skip all these middlemen. At any rate, once we've got angiotensin 2, those binds to the A1 and A2 receptors, and it causes the constriction of the blood vessels. This is also a very expensive drip, and I used it one time in my career because it's super expensive. All right, so here's a picture, because I know that, I wonder if I can move. Maybe I can't. Okay. I don't know if I can edit this while I'm I wonder if I can. tiny me. Okay. So here's that picture that said everything I just said in the previous slide, but sometimes it's a whole lot easier to see it kind of laid out in a map format. I know for me, it helps me keep my brain straight. So if you see here, we got the body. It's telling the kidneys, hey, I don't have enough blood pressure. I can't get this blood pumped all over, because the kidneys are not getting blood flow. So the kidneys go, okay, I got it. So they release this renin, goes over here. Angiotensinogen is produced in the liver. It's floating around. It causes the angiotensinogen to form angiotensin 1. And then we've got ACE, angiotensin converting enzyme, released from the lungs. It lives in the blood vessel walls of the lungs. And it gets released, and then it acts with the angiotensin 1 to form angiotensin 2. So angiotensin 2 does two things. I only talked about the blood vessels, but it also will cause aldosterone to be secreted, which will then cause our sodium to be reabsorbed in our kidneys. And what follows sodium but water? So this is important to know when we talk about diuretics. But when angiotensin 2 is circulating in our body, it causes it fills up those receptors, the alpha 1 and the alpha 2, causes those receptors to get activated. It constricts the blood vessels, causing a rise in blood pressure. And then it also causes the adrenal gland on our kidneys. It almost looks like a pancreas, but this is an adrenal gland, picture of it. Causes that to release aldosterone, which then causes us to hold on to salt. And what follows salt but water? Because they're married. They're attached at the hip. So this is what happens with that renin-angiotensin system. Well, it's complicated. So what does ACE inhibitors do? Well, what ACE inhibitors do is it takes this out of the equation. ACE inhibitors take ACE. ACE isn't even released, and it's just angiotensin 1 circulating in the body. So we don't have this, and we don't have this. So we have no extra water being held on to increase volume in our blood system, and our blood vessels are nice and relaxed. We're not constricting them. That's basically what an ACE inhibitor does. These end in pril. So these are your lisinopril, enalapril, and captopril. I see a lot of lisinopril. I see a lot of enalapril. I haven't really used a lot of captopril. I know that this, when it's in real high doses, it can cause some issues, which we'll talk about on the next slide. But these two I have used quite a bit. So like I said, it blocks angiotensin 1 from releasing or from converting into angiotensin 2. It also inhibits bradykinin metabolism. So this, we have extra circulating this. I thought I had a picture explaining this better. But what that is it's a peptide that it promotes inflammation. So when you have this being inhibited, the metabolism of this being inhibited, you have a lot of protein in your body circulating that increases or promotes inflammation. And that's important to know when we start talking about side effects. Okay. So here's a joke for that. ACE inhibitors, you get a lot of respect because they keep it pril. It's supposed to be real, but I'm a nerd, so that was funny to me. This was also funny. April, not sure if it's a month or an ACE inhibitor because it's got the prill. Ah. I'm sorry, I'm just a nerd. I can't really help it sometimes. I have a lot of medication jokes. I tell them at work and people get annoyed. But at any rate, I find it funny. It amuses me. Gets me through my day. Hope it gets you through yours. All right, important. Side effects of ACE inhibitors. This is one of the medications, right? Captopril. That is also the mnemonic that you will use to remember the side effects of ACE inhibitors. So let's go through it. C, coughing. You have a dry, persistent cough because the bradykinin. Remember, that causes and promotes inflammation. So you're going to have inflammation of the tissues in the lungs, tissues in the throat. So you're going to have a dry, persistent cough. There's no mucus production with this cough. It's just dry. A, angioedema. This can be life-threatening. So it's really important to catch it early and to get into an ER. And this is also due to that protein. It promotes inflammation. This is massive edema on the face, in sometimes the larynx, and I'll show you pictures of it. I mean, it is massive. People's tongues swell up. It is really, really dangerous. It's life-threatening. Potassium changes. This can cause hyperkalemia. Why? Because of the decreased aldosterone. When we have aldosterone, we tend to, or when we don't have aldosterone, we tend to keep potassium. So this can cause potassium not to be excreted through the kidneys and just held on to in the body. So we can see an increase in that. Taste change. This comes more when we have a high dose of captopril, which is one of the reasons there's another side effect that's related to high doses of captopril. So this is one medication I haven't seen a whole lot, but it's important if you have a patient that's on an ACE inhibitor, especially captopril, that you want, and they start saying that things are tasting weird or they have a weird taste in their mouth, that you let someone know. Hypotension, that is a side effect. It's a side effect of all blood pressure medications, right? But it's a side effect of ACE inhibitor. Pregnancy risk. These medications, it's a high risk, especially in the first trimester, for fetal development and I think miscarriages. At any rate, you want to make sure that if your patient is within the range of becoming pregnant, that age that they could become pregnant, you want to make sure that you avoid giving them ACE inhibitors, or make sure they have a plan to avoid pregnancy if they have to take an ACE inhibitor. Rash, this is also high doses of captopril. You develop a rash on your body. And then increased renin because of negative feedback. So the negative feedback, since it affects angiotensin 1 from being converted, it provides negative feedback for the kidneys to just put out more renin. And lower angiotensin 2, because it's what it does, right? ACE inhibitors stop angiotensin 1 to convert into angiotensin 2. So these people will have lower angiotensin 2. It can cause issues, especially if you need to have some reaction to get blood flow to your kidneys. You need a little bit of angiotensin 2, so that's where this can be a side effect. But for the most part, it is what it does, so you will have lower levels of angiotensin 2. That's weird. Okay. I'm gonna make me, it's like all delayed on my other screen. All right. Let me make me pop picture bigger. There we go. Okay. Blank screen. I didn't mean for it to be blank. So this is angioedema. Like I said, it is a medical emergency. Your airway is starting to swell shut. You have no way of getting air or food in. Your tongue is so big. So this patient here, very, very large tongue, a lot of edema on her tongue. She had to be intubated nasally, where they go through the nose and down into the lungs. Here you can see this person's eyes, they're very swollen. A lot of times you'll see swollen eyes and swollen tongue. And this swelling takes a while for it to go down. This person, they have a trach to be able to breathe, but this is in the process of angioedema going down. It's just, they're still very swollen. This is a larynx. That you can see, this should be a lot smaller. Don't know why I have a mouse instead of a laser pointer. There you go. This is all edema. This should be a lot more open, and if this continues, then you're going to have a hard time intubating these people, and they're going to have a hard time breathing. This is the progression of angioedema. So this is this patient's face. She was on an ACE inhibitor. You can see a little bit of swelling in her lips, and then massive swelling in her lips, and then her whole face, she's got swelling all over. So you want to be able to recognize this in your patients or your loved ones, family members, friends. If they're on an ACE inhibitor, you want to watch for this because it can develop pretty quickly, and then it can cause issues with airways and breathing. All right, so first line treatment for hypertension is diuretics. If we get rid of extra fluid, we're going to be able to lower our blood pressure because we have less volume circulating in our body. So remember, sodium and water love each other. With diuretics. It doesn't normally, but with diuretics, it gets rid of sodium even more, which gets rid of even more water. It says first line drug for hypertension. There's 3 types. There's thiazides, there's loop diuretics, and potassium sparing diuretics. And these 3, they work at different points of the kidney. So we'll talk a little bit about that. And some of them, well, I go over each one separately. So thiazides, these are medications. Some of them you'll have the ending of just thiazide. So you got your hydrochlorothiazide, your chlorothiazide. So hydrochlorothiazide is actually a combo drug. And a lot of thiazides, what you'll find is that they are a combination drug because you've got the diuretic portion, but then you also have like a calcium channel blocker, or you have an ACE inhibitor connected to it, beta blocker, that sort of thing. So this works on the distal convoluted tubule of the nephron, and I have a picture here in a little bit of a kidney, and we'll talk about where it affects. It decreases sodium reabsorption, and what follows sodium is water. So if the kidneys are not pulling sodium back into the body, it's pushing it out of the body through the urine. So water is going to go with sodium because they can't be apart, and you just pee it out. So this increases fluid loss, which will cause a little bit of hypovolemia, or not hypovolemia, it just gets rid of extra fluid in the body, which will then decrease the circulating volume, which then will decrease your blood pressure. It also will cause potassium loss. A lot of our diuretics we're going to lose potassium with. The only ones, which we'll talk about, that don't is the potassium sparing ones. Those are very weak, so we tend to see more of the thiazides and the loop diuretics. This does retain calcium, so these patients are not going to lose calcium. And like I said, it can be combined with some of the blockers to enhance the hypertension control. And these you can use for a long time. Some patients are on these for a long, long time, and it really does help with their hypertension. So this is where the distal tubule right here. So this diuretic, if we take a little chunk out of the kidney out and we go over here and we stretch out the nephron, you'll see here that we've got the distal tubule over here before we go into the collecting ducts. So right here is where thiazides work, in the distal convoluted tubule. Okay. Loop diuretics. These are ones that a lot of people are familiar with. You tend to see a lot of patients, they have a water pill. They either mean hydrochlorothiazide or furosemide, which is also known as Lasix. These are very, very potent. So you got furosemide, which is Lasix, and bumetanide, which is Bumex. Lasix and Bumex. So these work on the loop of Henle, thus loop diuretics. And they are super aggressive. They make you pee everything. So you are losing sodium, potassium, chloride, other electrolytes. They don't get absorbed, so your water just follows everything. There's a huge fluid loss. So if you give your patient a loop diuretic, especially by IV, you are going to have your Foley bag fill up like crazy. You better make sure you have a bedside commode, a urinal, or something nearby, because these patients are going to be peeing, and they're going to be peeing a lot. It's impressive. It works very quickly. A lot of times these patients will say, oh, I need to take my Lasix at 5 so I'm not up all night peeing, because it does work very quickly. One thing, since it gets rid of all of these electrolytes, you're going to really want to check your potassium levels. A lot of times when I have a patient that I'm giving IV Lasix to, I'm almost certain that I will have to replace potassium. These patients' potassium drops very low very quickly. Some of these patients, even when they're on Lasix, they will get real bad cramping because their electrolytes are lower than what we typically would have. All right, so here is that kidney picture again, and here, if you look at here, this is where the loop diuretics work, in the loop of Henle. How cool would it be to have a body part named after you? Even if it's real tiny. Loop of Henle. Nobody knows who Henle is. Well, somebody does, but you can't forget loop of Henle. Be cool. I don't know what body part I want named after me, though. Whoops. And here, because I thought it was funny. When you check your watch and it's time to take your Lasix, this person is super, super swollen. A lot of times our patients who have congestive heart failure, and those patients in heart failure, they have a lot of fluid retention. They get super, super swollen. Sometimes you have really bad pitting edema. And so this patient needs to take their Lasix. Get rid of some of that extra fluid. So last group of diuretics is our potassium sparing, and that's the one that works on your aldosterone. So you got this aldosterone receptor right here, and what the what your potassium sparing drug does is it blocks aldosterone from retaining sodium. So sodium ends up getting excreted out through the urine, but potassium gets spared. So, there's more drugs in these classifications than what I'm showing you, but the ones that I'm showing you are ones that I'm more familiar with throughout my career. So, spironolactone and amiloride, those are the two that I have used more. This one, the first one, than the second one. And pretty sure this one you can also, when people have really bad, I think, cystic acne, you can use this as well. This somehow helps with that. But that's a topic for another time when we talk about skin and being a teenager. No. Okay, so this works on the collecting duct, and this is how it works. Sodium goes into the cell and potassium goes into the cell, but in the sodium-potassium pump. But the potassium sparing causes the sodium not to enter, but the potassium. So then the potassium can go the potassium gets spared, and the sodium ends up being excreted through the urine. It works on aldosterone receptors, and it blocks it from retaining sodium, which then causes it to excrete sodium in water. These are very weak, so you don't really see it as often in some of our patients that really need diuretics or really need to lose a lot of fluid. And sometimes you'll have combination. Sometimes you'll have patients that are on a thiazide and a loop diuretic, or a thiazide and a potassium sparing. It just kind of depends on what works for each patient. So, all right, let's get on with some questions. And I think I have maybe three or four. So, a patient is being discharged. This is a CCRN question. Patient is being discharged after being treated for hypertensive crisis. Remember, hypertensive crisis is extremely high blood pressure, during which she experienced dyspnea and chest pain. Which of the following statements about patient education is accurate? Excuse me. Oh. Choose all that apply. Taking medication is extremely important in preventing damage to other organs. If you are experiencing early symptoms of malignant hypertension, seek immediate medical help. Do not engage in any physical activity. Many patients are asymptomatic in a hypertensive crisis. Okay. Patient is being discharged after being treated for a hypertensive crisis where she had dyspnea and chest pain. Which of the following statements about patient education is accurate? All right, so if you remember, when we were talking about medications or hypertension and other organs, if we don't control hypertension, it can cause damage to the other organs, right? So it is important to take your medication to prevent damage to other organs. So we'll say check. This one is 1. If you are experiencing early symptoms of malignant hypertension, seek immediate medical help. Well, that's important, right? Because if you're in malignant hypertension, malignant meaning dangerous, right? When you have a malignant tumor or you have malignant hypertension, it can cause death. It's very dangerous. So you want to seek immediate help. So this would be correct. Malignant hypertension can often be also hypertensive crisis. Do not engage in any physical activity. Well, we want our patients to be moving. It's very important for them to be moving. And exercise is important, especially for patients with hypertension. You don't want them to go out and run a marathon maybe, or lift real heavy weights. You want to slowly get them back into exercising. So you want them to have some physical activity. You don't want them to have zero. So this would be a no. Many patients are asymptomatic in a hypertensive crisis. So one thing I will tell you is some patients, if they have hypertension and it gradually comes on, then they don't really develop the symptoms of hypertension as a person who just all of a sudden has a blood pressure that skyrockets. So when patients, most of our patients who are in a hypertensive crisis, it's been slowly creeping up, and then all of a sudden it just gets into that range where it's a hypertensive crisis. It's above the 180 systolic mark. So these patients often don't experience headache. They don't experience chest pain, shortness of breath. These patients just are walking around with this extremely high blood pressure. But they come in and we find out that their blood pressure is extremely high, and we have to start treating them. We also have to start treating these patients slowly because their body is used to that high blood pressure. And if you drop it too quickly, too suddenly, then their body starts thinking that they're hypotensive. So they start having the symptoms for hypotension. At any rate, this is also correct. Many patients are asymptomatic in a hypertensive crisis. So this patient did experience some symptoms, but a lot of times our patients, they may be asymptomatic because they just are not, their body is developing a tolerance to the high blood pressure. Okay, good. So A, B, and D. All right, next question. Ooh, didn't mean to do that. A nurse is evaluating a client with hypertension and benign essential tremor who has just started on propranolol 3 hours ago for treatment. Which of the following findings is most concerning and should be prioritized for reporting to the healthcare provider? Okay, so we've got client has a blood pressure of 150/90. Client has a heart rate of 68 beats per minute, down from 80 beats per minute. The client has wheezing on auscultation. Client has a headache. So, which of the, a nurse is evaluating a client with hypertension and benign essential tremors who just started propranolol. So here's that drug. Remember, propranolol is one of those drugs that hit both beta 1 and beta 2. Just started propranolol 3 hours ago for treatment. Which of the following findings is most concerning and should be prioritized for reporting to the healthcare provider? All right, so what do we know about propranolol? Well, it's got this. It's got LOL, the LOL. So we know it's a beta blocker. And remember, there's cardioselective and non-cardioselective. Propranolol is one of those that is a non-cardiac selective. So it's hitting both beta 1 and it's hitting beta 2. So when beta 2 gets blocked, because when beta 2 receptor sites get activated, we have bronchial dilatation, right? Beta 2 is in the lungs. Remember our little diagram. Beta 1 is in the heart, and beta 2 is in the lungs. So when beta 2 is activated, we have our bronchioles dilating, right? We need to get air flowing so that we can run faster. So if we block that, then we cause constriction. So we have bronchial constriction. Ah, no. Okay. So that's what we know about propranolol. Let's read our answers again. The client has a blood pressure of 150/90. This is high, right? But he's only been taking it for 3 hours. Propranolol is not going to act that fast. Maybe if you give it IV, but it doesn't tell us that. So this will take some time for it to start working. So A is normal. A client has a heart rate of 68 down from 80. Well, it's a beta blocker, and beta 1 is cardio, is in the heart. So it's known to lower your heart rate and cause your vessels to dilate, right? So if their heart rate drops down from 80 to 68, that's normal for propranolol. The client has wheezing on auscultation. So this means that their bronchioles are constricted, and propranolol can do that. Is that a good sign? Well, if you're wheezing and you've got bronchial constriction, that means that you're not getting enough oxygen into your lungs to oxygenate your body. So this is a contender, right? We want oxygen. We need it. The client has a headache. When we have vasodilation, we can cause some of those blood vessels in the brain to dilate as well, which will cause headaches. So as your body isn't used to the medication yet, you can get a little bit of a headache. You can get a little bit of dizziness. You want to watch for those things, and if they don't go away, then you want to address it. However, this patient just started it. This is going to be a normal reaction until his body adjusts to this medication. So D is not the answer. C, if you picked C, because of the beta 2 blockade, try to be more professional in my talk. Because of the beta 2 blockade, the patient is wheezing. We're not getting enough oxygen, so this is priority. ABCs, airway, breathing, circulation. I think this is the last one. Maybe. Okay. Patient is being discharged home on hydrochlorothiazide for treatment of hypertension. Which of the following statements by the patient indicates they understood your discharge teaching about this medication? Blah. Can't talk. I will make sure I consume foods high in potassium. Bananas. I understand a dry cough is a common side effect of this medication. I will monitor my glucose levels closely because this medication may mask symptoms of hypoglycemia. I will only take this medication if my blood pressure is high. Patient is being discharged home on hydrochlorothiazide for treatment of hypertension. Which of the following statements by the patient indicates they understand your discharge teaching about this medication? All right. So what do we know about hydrochlorothiazide? HCTZ. It's a diuretic, right? It causes sodium and potassium to be excreted, right? And with that, it goes away with that water. Okay. So let's read these answers. I will make sure I consume foods high in potassium. Well, we are throwing away some potassium, so this is a good contender, right? This patient is going to want to make sure we're replacing potassium with those bananas. Oh, man. I understand a dry cough is a common side effect of this medication. Which antihypertensive medication causes a dry cough? Remember that medication, ACE inhibitor, will cause that protein to be circulating, which promotes inflammation. So, if you remember, it's ACE inhibitors that can cause that dry cough because of inflammation. So this would be an ACE inhibitor. I will monitor my glucose levels closely because this medication may mask symptoms of hypoglycemia. Symptoms of hypoglycemia, that would be increased heart rate, right? Hunger. What medication can cause that? What medication lowers your heart rate? That's your beta blockers, right? Because they block those beta receptors. So this would be your beta blocker. I will only take this medication if my blood pressure is high. Now this goes for all blood pressure medications. You don't want to take it when it's high. You want to take this all the time to prevent your blood pressure from going high. So this definitely is not it. So B isn't it, C isn't it, D isn't it. If you picked A because you get rid of potassium, you are correct. Last one. Patient with hypertension is started on a new medication for treatment and is reporting a continuous dry cough. Which of the following medications do you suspect is causing this problem? We've got lisinopril, labetalol, losartan, hydrochlorothiazide. All right, so which medications are which? Lisinopril, remember we look at the last few letters of the medication and it'll tell us, it'll help tell us what each of these are. Give me 1 second. Okay. This is what I thought, so I had to double check it before I told you all something wrong. All right, so lisinopril, we got our pril. Whoop. Remember that joke, April, don't know if it's a month or an ACE inhibitor, because A for ACE inhibitor, pril for the medication. So this is an ACE inhibitor. Labetalol, that has an LOL here. Which medication knows that it's that laughter is the best medication? Because it likes to laugh, LOL. That's your beta blockers. Your beta blockers like to laugh. Losartan. Now this is the drug classification that I didn't go on over in this study session, but there is another medication called ARBs. That's another blocker, and what this does is it's a angiotensin 2 receptor antagonist. So this is one of those ARBs, angiotensin receptor blocker. And this is the one that we're going to go over next week. So this would fill in the receptor sites that angiotensin would attach to, thus causing angiotensin not to really do anything. It's still, you're still going to get angiotensin because it's going to convert. It's not an inhibitor for ACE. It just prevents angiotensin from attaching to those receptor sites. And we'll go over more detail of that next week. And then we got hydrochlorothiazide. And there we got thiazide, we got diuretic. Okay, so this one, beta blockers, depending if it's cardioselective or not, we can have a decreased heart rate. We can have dizziness, headache. You don't really have a dry cough, right? That really doesn't do it. We can have wheezing if it's non-cardio specific. Diuretic. With a thiazide, you may have low potassium, right? Hypovolemia, it's not super strong diuretic, but nothing about a dry cough. Losartan, let's say you don't know what that is because we didn't go over it. So we know it's not D, we know it's not B, so it's either A or C. Well, remember, ACE inhibitors can cause bradykinin to be increased, which causes an increase in inflammation because it promotes it, which can cause you to cough. So this is the one that will have a dry cough. You'll have a rash sometimes. You'll have angioedema as a side effect. So if you picked A, lisinopril, because it's an ACE inhibitor, you are correct. And that is the end of our study session. So I hope you learned something about hypertension and some of the medications. It was very hard for me in school to do pharmacology because I was not very good at memorizing things. And pharmacology, I feel like you have to really memorize things. But if you're able to think through how the medication works in the body, and if you're able to make connections, funny ones, or however you can do it in your head, it'll be easier to remember. For those of you who do not memorize things very well like me, try and make sure you find those connections. Understand how the body works and how the medication works in the body, and it'll be a lot easier for you to remember and pass your tests. So until next week, we'll talk a little bit more about cardiac drugs, unless one of you sends me a question. I hope you guys do. You can message me, Instagram, Facebook, Gmail, whatever you think. Like, follow, subscribe across all those social media platforms so you can stay up to date on things. And I hope you all have a great week, and I will see you next time.